Hello, and welcome to Stroke Prevention and Atrial Fibrillation, Overcoming Barriers, Improving Patient Outcomes. I'm Dr. Jeffrey Saber, Director of the UCLA Stroke Center, and joining me today are Dr. Mark Alberts, Director of the Stroke Program at Northwestern Memorial Hospital in Chicago, Dr. Gerald Nacarelli, Chief of the Division of Cardiology at Penn State University College of Medicine, and Dr. Eric Prystowski, Director of Clinical EP at St. Vincent's Hospital in Indianapolis. Today, we'll discuss four key issues: the growing impact of atrial fibrillation in the United States and its effect in increasing the risk of stroke, the benefits and barriers of currently available antithrombotic agents, emerging antithrombotic strategies for preventing stroke and atrial fibrillation, including late-breaking information presented here in Chicago at the AHA 2010 scientific sessions. And lastly, non-anticoagulation strategies and their potential role in reducing the risk of stroke in AF. First, let me set the stage by discussing the scope of the problem that atrial fibrillation poses for the American healthcare system in the United States. Atrial fibrillation affects 5.1 million individuals in the U.S. currently and is expected to increase by 2 to 3-fold by the year 2050. So it will affect 12 to 15 million Americans. The annual incidence of stroke with atrial fibrillation is 5 to 12%, and currently less than half of eligible patients who have indications to receive antithrombotic therapy are doing so. Strokes in atrial fibrillation are a frequent and all too severe a phenomenon. 15% of all ischemic stroke patients, about 1 in 6, have atrial fibrillation. Atrial fibrillation is seen as a cause of stroke more often in women than in men because women live longer and there are a greater number of women, even though at any given age, atrial fibrillation is more common in men than in women. Atrial fibrillation patients with stroke have increased morbidity and mortality compared to other causes of ischemic stroke. In fact, the one-year mortality after an ischemic stroke with atrial fibrillation is 50%. 1/3 of patients who have atrial fibrillation and stroke were not known to have atrial fibrillation until their stroke. It was the presenting manifestation of their AF. And more than 50,000 strokes each year could have been prevented if antithrombotic therapy, according to national guidelines, had been used, and are preventable but missed opportunities for care. Now let's turn to our panel, and I'll begin with Dr. Alberts. We know the risk of stroke is increased in patients with AF, Mark, but what kind of strokes do we see in these patients when they occur?
Yeah, well, that's a very good question and a good point, Jeff. As you and I know, but some of our colleagues in other areas may not be familiar with, the types of strokes we see in patients with AFib tend to be large hemispheric strokes that are devastating. They typically come on rapidly without any warning. There's no TIA before the stroke occurs, so we don't have an opportunity or a window to intervene to prevent that stroke from occurring. That's why prevention is so important. And as we know, the types of strokes that we see in AFib do not really respond all that well to our acute therapies like TPA and endovascular therapy. Many of these strokes are due to clots that have been in the heart for a long time. They're large, they go up to the brain, they're very hard. They don't respond to thrombolytic therapy, and you can't do the Mercy device because it's hard to put a corkscrew into a brick. And some of these clots, as we well know, are hard as a brick. So our acute therapies are really limited, and these patients typically have devastating strokes that can kill them or leave them disabled forever.
Great, Mark. And let's move on to our current antithrombotic therapies, because the best way to treat a stroke is to keep it from happening in the first place. What are the benefits and barriers to the current mainstay of stroke prophylaxis in atrial fibrillation, warfarin?
Right. Well, warfarin is very effective when used appropriately in a high-risk population. The relative risk reduction is at least 67%. And if you look at patients who are on warfarin with therapeutic INRs, then the relative risk reduction is 75 or 80%. But as we know, warfarin is a great challenge to use. You have to check the INRs all the time. There's food and drug interactions. And as you pointed out a few minutes ago, the majority of people in AFib who should be on warfarin don't take it because of either patient concerns or physician concerns. So it's a great drug when used properly, but there are a lot of barriers.
And Mark, can you talk to us about the target anticoagulation range for warfarin in atrial fibrillation? What do we know about the optimum range and how often it's achieved.
Right, so it's important when you take warfarin to keep the INR between 2.0 and 3.0, although some more recent studies suggest that 1.8, 1.9, probably okay, and up to 3.5 is probably okay. But again, because of multiple food and drug interactions, because of issues with monitoring, patients can't get there, physicians don't monitor it as closely as is needed or as is necessary, a lot of patients fall out of that therapeutic range and they're really not protected.
Very good. And for patients who can't take warfarin, there has been a study, the Active-A study, that showed that clopidogrel plus aspirin was effective and more effective than aspirin alone for patients unsuitable for vitamin K antagonists. Yet the guidelines recently released in October 2010 by the AHA did not recommend the use of clopidogrel and aspirin in that patient population. Can you tell us why?
Yeah, so I think one of the major things driving that was the fact that the combination of aspirin and clopidogrel in this high-risk AFib population was actually associated with more bleeds than aspirin alone. And in fact, the rate of bleeding with aspirin plus clopidogrel was roughly equivalent to that of warfarin. And so I think the thinking was, gee, if the risk is similar to warfarin, even though there's more efficacy than aspirin, there's certainly not more efficacy with aspirin and clopidogrel compared to warfarin. Just use warfarin and find a good reason to use it. So I think that there are some challenges and some limitations with that. And as we know, there are newer agents that are available and may become available that may solve part of this quandary.
Great. Well, let's turn to those newer agents now. Dr. Nacarelli, can you tell us about the emerging options for anticoagulation therapy? Are there viable alternatives to warfarin?
Yes, Jeff, it's an exciting time right now, and there's a number of new anticoagulants that are being developed. They've really fall in two broad categories. Oral direct thrombin inhibitors, dabigatran. This was studied in the RELY trial, and we could talk about that in a second. And then there's a whole host of fascinating drugs called direct factor 10A inhibitors. There's a drug called apixaban that recently had some data showing superiority over aspirin in the Averroes trial. The big pivotal trial is ongoing called Aristotle. There's a drug called bedrixaban that is finished some phase 2 studies. Will be going to phase 3 soon. There's a drug called edoxaban, which is in a phase 3 trial called Engage-AF. And just at this Heart Association meeting, there's a drug called rivaroxaban, and we just learned actually earlier today some data about that. So let's concentrate on the two drugs we know the most about, dabigatran, which actually happened to get commercially released in the United States and Canada just in the last week or two, and then we'll talk about some of the results from ROCKET-AF. RELY was published actually back in 2009 in the New England Journal of Medicine. There was over 18,000 patients. And these patients had atrial fibrillation with risk for stroke, and they were randomized, about 6,000 patients in 3 arms. One on therapeutic warfarin, trying to keep an INR between 2 and 3, and actually they were able to keep the time in the therapeutic window about 64% of the time, which is pretty good, probably pretty equivalent to most anticoagulation clinics. Low dose dabigatran, 110 milligrams twice a day, and then a higher dose dabigatran at 150 milligrams twice a day. What the findings of this trial were interesting. The lower dose, 110 milligram dose, was shown to be non-inferior to warfarin for the composite endpoint, which was a composite of stroke and systemic embolic events. But a surprising finding was that the higher dose, 150 milligrams twice a day, was actually superior to warfarin. So that was something I think we were all surprised at as an investigator. But it was not only superior to the warfarin arm, it actually was also superior to the lower dose dabigatran arm. And another fascinating finding of this trial was both doses of dabigatran had a major reduction in intracranial hemorrhage, and that was kind of exciting. Major bleed rates were really no different. There was a little higher GI bleeding, though, in the dabigatran group. So that drug, and interestingly, in the United States, was released at 150 milligrams twice a day, and there's a lower dose at 75 milligrams for people with renal dysfunction because the drug is heavily renally cleared. Interestingly, in Canada, it was approved at the 150 and 110 milligram dose that was studied in that trial. Now, As you know, Rocket AF came out just today, and several years of work by a great group of investigators. Now, in this trial, rivaroxaban, which is the first trial for 10As to come out, was studied once a day, and it was over 14,000 patients. So there's about 7,000 patients in the rivaroxaban arm and about 7,000 patients in the warfarin arm, again, trying to maintain the INR between 2 and 3. In this trial, the time the therapeutic range was about 58% with warfarin. What was exciting, their primary outcome was a non-inferiority compared to warfarin, and they showed that, and actually the risk reduction was 21%, which was statistically significant. What was interesting, they had a statistic that the way they did their methodology was that if you met non-inferiority, they then went on to look at superiority by intention to treat, and actually that did not show a statistical benefit, but when you looked at the on-treatment effect, there was a similar statistical reduction with a hazard ratio of 0.79. So the other key finding in this trial was that major bleeds were very similar. There was no other signal of major concern, and it was somewhat interesting in this trial was that the CHAD score was very high. It was like 3.47 on the average, and it was about 2.1, 2.22 in RELY. But that was by design. They had actually enriched the population to study a group with more risk factors, and we knew it was going to be higher. We just weren't sure. So it was kind of a very exciting finding from the study, and the data hasn't been fully published yet. It's being in preparation, and but that was like kind of the big news of the day today.
Very good. And the indirect comparisons are always treacherous. There are important design differences between these studies, and the patients in Rocket and the patients in RELY clearly are very different patient populations. Do you think we're going to be able to make sense of the comparison between the two, or need to work that out in future studies?
It's a great question, and I'm sure people are already scratching their head about the differences. I think there's a lot of similarities, though. They were both huge trials, right? They were both compared to warfarin. They both proved their endpoint. There's a lot of breakdowns, and I think one has to be a little careful in comparing trials. For example, in RELY was open label. You were randomized to warfarin or 2 blinded doses of dabigatran. In the Rocket AF, it was a double-blind, double-dummy, and slightly different methodology. So you get into a lot of differences, such as that the sicker population at high risk for stroke in the Rocket AF trial. And I think that we'll all be eager to kind of make those comparisons. We're going to have to be very careful. I would like to see the full database. I think at least with RELY, the data's been published, it's been vetted. We have all the data. In fairness to the Rocket AF investigators, they just presented the data today. They just had a data lock not that long ago. The data's probably still flying, and I'm sure we'll see more about this fascinating drug soon.
Well, we have a battle of the bands coming up, but it does seem that warfarin's days are numbered. Let's turn now to other strategies than antithrombotics for preventing stroke in AF. Dr. Prostowski, can you give us an overview of the non-anticoagulation strategy?
Sure. Thank you, Jeff. There's been interest in this for many, many years. If you go back in the surgical literature, you'll find patients who had strokes with mitral valve disease. One of the ways to treat them was to take off their left atrial appendage. So this is not a new concept, but it's a concept that's growing in popularity as far as trials are concerned and devices. So if you're taking a look at a patient and you're saying, well, some patients just simply don't want to take drugs. So regardless of whether it's a 10A inhibitor, Jerry, or if it's a thrombin inhibitor, or it's warfarin, some people just don't like to take drugs. So are there non-drug options? And then there's a large group of patients where they really are not good candidates for any of the anticoagulants. So let's kind of just dissect through those. It all starts at the left atrial appendage, because the concept would be most thrombi that get dislodged and go to the brain start in the left atrial appendage, but not all. And I think we have to be a little humble about this. It's not like it's not a binary 0-100. I mean, 95% in most of the TE studies, approximately. So at least 5% in other places. So we have to be a little careful. So the first and easiest thing is let's just take out the left atrial appendage. So there have been surgical studies that have looked at doing this by either, literally excising it, and there have been others where they take it out theoretically. In other words, they'll leave the appendage in, but they'll occlude it somehow with a variety of tools. And if you look at those data, they're not overly good as far as really fulfilling their mission. For example, if you look at TEs afterwards, there's a fairly high percentage of them that still have pockets that can have thrombi, and indeed, thrombi have been noted. Now, much more recently, there's been a preliminary trial done with a new type of a clip. And remember, I'm an electrophysiologist, not a surgeon, so before I have 5 million cardiothoracic surgeons dialing in and telling me I misquoted something, I'll just simply say there's a new clip that in the surgical literature is got 100%. Now, indeed, that'll never hold up. There's nothing in the world that's 100%. So the preliminary data are very encouraging. And the important thing to remember is there's a lot of interesting new devices I'm seeing in a sort of a very preliminary animal stage, and they're all looking for a way to do this without actually cutting in and taking a look at the beating heart. And I caution all those folks to remember that so far surgeons who are pretty darn good with the heart in their hand trying to exclude it have had a hard time before this clip came along. So I think we have to be a little bit cautious about this. So that's sort of the left atrial appendage that way. And then there are things to plug it up. So there have been at least 2 devices that the most recent one, the Watchman trial, that have taken a little device and put it through a transeptal delivery system into the left atrial appendage, allow anticoagulation for about 45 days or so to let it endothelialize. Actually, the results weren't bad. It was the Protect AF trial, and they met their non-inferiority. Unfortunately, there were a fair amount of complications, but a lot of those complications were learning curve complications. This is a tough technique, and they've learned different things along the way. That all said, in the United States, it's not been approved yet. It went up before the FDA, and they took a pass on it. They're asking for more studies. I'm personally excited by that area, though. I think it's definitely something for the future, and when they can get the complication rate down, I think it offers us an advantage for our patients that we don't have now. Because we still, no matter what new anticoagulants come along, if you have a patient who can't take one, what's your alternative? Right now, kind of a wing and a prayer. We don't have a good alternative. So those are the actual devices. And then there are 2 areas that I think are fun. Ablation to cure Afib. Now, I understand, before I get all the calls from my colleagues, that there's no data to prove that yet, and I accept that. But I'm pretty bullish on this for the future. I think we need more trials to be sure, and we're going to have to pick the right patients. But unlike drugs that we know there are a lot of silent recurrences, you could look more carefully at the ablation population, even with things like implantable loop recorders, to see if they're having recurrences. And a lot of these patients are truly cures. We don't have the database yet. The preliminary studies are encouraging, but that's all I would say. But I look to the future where we'll be able to do an ablation to get people off of antiarrhythmic drugs and antithrombotic agents. We're not quite there yet. And the last of all is a curio to me. I'm not exactly sure why this happened, but in the Athena trial, the drug dronedarone, which is not an antithrombotic by design, in a subgroup analysis, and we all know that's a bit dangerous, in a subgroup analysis, it was shown to reduce strokes across the board, not dependent on whether a person was assigned to warfarin or other drugs. So I don't know why that is. I think it's intriguing. I'm not at all suggesting that one prescribe dronedarone to reduce strokes, but it is interesting, and I think it demands more study.
Well, these are exciting times both in medical therapy and in device therapy, and we have exciting new antithrombotics for patients who can take anticoagulants and emerging options for patients who are not eligible for anticoagulants. So as we enter this new era, let me ask each of you who, like I, have lived and struggled through the warfarin age, as we now are on the precipice of its end and the start of something new, to reflect on what comes next, life beyond warfarin. Mark?
Well, I think life beyond warfarin is going to be very exciting for both the physicians and patients because we have new agents in different classes, as Jerry was saying. And I think there's going to be a learning curve for both physicians and patients to learn how to use these new agents, when to use them, when not to use them. And as Jerry talked about, these agents are going to have very fast onset of action. So it's something to be very careful about. But the other point is that as more and more older patients reach the age where they get AFib and need to be treated, many of them, as we heard, are going to have contraindications to anticoagulation. So I think the use of some of these devices and trying to get them out of AFib is going to be very important as we go forward.
Jerry, no more rat poison? What will that be like?
I think there's some real excitement here. We know that almost half of the patients who should be on warfarin in the United States are not. And now we're discussing all these new medications, and I think, with all the education and discussion and publication, it's going to highlight this area. And whether they're on warfarin or some of these new drugs or some of these other approaches, I think you're going to see more patients treated. I think one of the things that will move these novel agents further, of course, is more information, safety, and we don't have an antidote right now. We didn't talk about that, but there's not an antidote to reverse some of these novel drugs yet, although the good news is they get out of the system pretty fast, and there's some ways of dealing with that. So I think as things move along, you're going to see a lot of excitement in this area. I don't think the anticoagulation clinics will quite close yet. A lot of patients have done well in warfarin for a long time. I'm not sure they're going to be the first patients that would get switched. I think a lot of new starts for these novel drugs, a lot of patients who are the bad actors, the ones we can never keep in the therapeutic range, would be my second group. And then there's going to be a lot of patient demand for this. And I agree with Eric, maybe have him comment that there's a lot of excitement in the non-blood thinning field also.
Yes, and thanks for pointing out it's really going to be the warfarin plus, not after warfarin, but warfarin and others. And Eric, what's your view on this new age that's dawning?
Yeah, I share the excitement of my co-panelists. I also put a few precautions in there. And I will tell you, I have a pretty big AFib patient population, and we've had it for 2 weeks now, the drug. So not a lot of experience. So as they say, one swallow does not a summer make. So I don't want to make a lot out of this, but I thought everyone would be just, bowing down as I offered them dabigatran. And it hasn't been quite the case. I'd say about 50% to 75% have said right away yes. And then when the money issue came in, these are elderly patients. I've had 3 or 4 of them say, I want to check my insurance companies first. Even though I gave them the big build-up, it's better and so forth, and you don't have to do all those finger sticks and whatever. So I don't think it's going to be 100% switch. I think there are things we don't think about that patients deal with. But we also have to remember that we don't have the full data set for the use of this versus warfarin. For example, cardioversion. I'll accept the fact that in the dabigatran trial, people on chronic doses of dabigatran, if you compare those to people on warfarin, had similar episodes of stroke with cardioversion. They're both low. So I'm okay with that. But what do you do with the person, Jerry, you see in the office tomorrow, and they're in a persistent AFib and you have to plan cardioversion? I'm not at all comfortable at the moment with how to handle that patient without a TEE. I think maybe a TEE, if a TEE negative and you started them on the dabigatran, I feel pretty comfortable that you've got them fully anticoagulated. But without that, is it 3 weeks, Jerry? Is it 2 weeks? Is it 4 weeks? I don't honestly know. Some people are positing that maybe what we should do is the old-fashioned way with warfarin, let them get anticoagulated, and then once they're in a stable state, switch them over. I mean, honestly, I don't know. And that's a common situation. So I think we have to understand that there's still things we don't know and be a little careful in our use of these drugs.
Great. Well, Eric, Jerry, Mark, thank you so much for joining us today. Let me summarize that we've learned that the problem of atrial fibrillation is with us for the long haul. As the U.S. population ages and the baby boom generation ages into the AFib years, the prevalence of atrial fibrillation will increase, doubling or tripling during the practice lives of everyone watching this video. While warfarin has been the mainstay of anticoagulation therapy to prevent strokes, there are substantial problems with it, as we all know. And the exciting news is that new oral therapies are here and becoming available in practice, the oral direct thrombin inhibitors and the oral factor Xa inhibitors as new options in antithrombotic therapy. In addition, non-anticoagulation strategies are becoming more powerful and offering the hope for patients who absolutely can't take anticoagulation and a potential promise of making anticoagulation unnecessary for more patients in the future. I want to thank my colleagues again for this excellent discussion, and thanks to you, our viewing audience, for your participation today. We hope the information presented will be useful for you in the care of your patients with atrial fibrillation. Please remember to complete the post-test evaluation in order to claim your CME credit. Thank you very much.